Welcome, everyone. Namaste. Really good to see you here in the new year. Happy New Year 2025 to everyone. If you don't know me, I'm Dr. Ramu Kharel, and I am an assistant professor of emergency medicine at Brown University, and also one of the founders of the Nepal Poison Center. We've been working on this for the last year and a half, and as you all know, we have had many amazing webinars every month and topics that are pertinent to Nepal, and we've brought speakers from around the world, experts who are top of their field. So we're always really excited about this activity, and we get a lot of engagement from you all as well. So we're really happy that you have joined in our first webinar of 2025. And today's webinar is special for its topic as well as for the presenter that we were able to get. So the topic today is going to be really one of the most common problems in poisoning that we see in our country is plants-based anticholinergic syndrome. And we all know that Dhatura is one of the top plants that can cause this in our country, but there are many others. But also cholinergic problems with organophosphate is really common, which is sort of the opposite of this, which I think there are a lot of questions regarding that. So we'll be discussing that as well. Now on to introduce our speaker for today. It's none other than our very own Dr. Ziad Kazzi. Dr. Kazzi is a professor of emergency medicine, and he's the International Toxicology Fellowship Director at Emory University. He's also one of the leads and founder and past president of Minatox, which has a large impact in the Middle East as well as Northern African region when it comes to toxicology. As a matter of fact, they're hosting their conference coming up in February 23rd to 26th, where there will be a lot of participants from Nepal as well. So if you're interested in going to the conference, it's going to be in Oman, very near, kind of doable for Nepalis to fly to. So definitely do check out the Minatox website. So Dr. Ziad Kazzi has also been one of the keen supporter of our Poison Information Center and one of the mentors that has guided us in coming this far. So we're really happy to begin our first webinar of 2025 with Dr. Ziad Kazzi present here. And I would also like to thank all our other Poison Center staff, as well as our partners who have joined here today, as well as all of you participants. So without further delay, please join me in welcoming Dr. Ziad Kazzi for our presentation today. If you have questions, please put in your chat and we will address them at the end of the presentation. Dr. Kazzi, the floor is yours.
Thank you, Dr. Ramu. Congratulations to Nepal for what you've achieved in the past year and a half, although it feels like we've been working on this for more than a year and a half. But I hope this momentum and achievements that you all have continue to grow and be sustained in the future. What you're doing is important. Poison centers save lives. Poison centers decrease utilization of healthcare systems. Also, unnecessary use is also averted. Poison centers prevent poisonings, detect hazards to the public, and are just an amazing power of good in your community, in your society. I hope you always cherish this resource and support it. I'm also very proud of Dr. Ramu's achievements. Dr. Ramu was my resident several years ago at Emory, and I've always knew he was going to be a star, and I always knew he was going to be committed to Nepal, and I'm very happy to see that he's fulfilled that way. So I feel the same way for Lebanon. I'm originally from Lebanon, and I will share today some cases in Lebanon. I've done the similar journey with Ramu in Lebanon, where we started toxicology service at the American University of Beirut, and I will be sharing some of our cases there that I've seen. I know there is some interest in organophosphate poisoning as well. We will discuss that at the end. I think we can. This presentation is not that long, so we'll try to discuss cholinergic and anticholinergic toxicity, so both sides of the coin. The main topic of today is really the anticholinergic toxidrome. So that's something that you will see in the emergency department I am going to talk about treatment primarily because there's an antidote for anticholinergic poisoning called physostigmine. I don't know if you have it in Nepal. You may, because we'll talk about it in a little bit. You may have this antidote, or maybe it's an antidote that's similar to it. So it's important to talk about it a little bit. But the anticholinergic syndrome is really due to an excessive amount of acetylcholine. I'm sorry, sorry, brain fart. It's The anticholinergic syndrome is due to the blockade of the acetylcholine receptors in the muscarinic system, whether it's in the central nervous system or in the peripheral nervous system. So basically, you have the acetylcholine receptors that are blocked. These receptors I'm talking about are not at the neuromuscular junction. I'm talking about the acetylcholine receptors that are present in the brain, the ones that are present in the peripheral system, for example, in the salivary glands, in the bladder, in the intestinal tract, in the AV node. So this is what muscarinic receptors I'm referring to here. And when you have a blockade of these receptors by a chemical, you can develop an anticholinergic syndrome. This is different than the cholinergic syndrome, in which you have an excessive amount of acetylcholine at these muscarinic receptors. Okay, so we are talking about the anticholinergic disease entity at the beginning here. And the signs and symptoms that you see are going to be in the central nervous system as well as in the somatic system, but not the neuromuscular system. Remember that. Because the neuromuscular system, the acetylcholine at the muscle junction is a nicotinic receptor. And we're not talking about that here today. We're talking about anti-muscarinic effects. So muscarinic receptor blockers or antagonists that lead to this anticholinergic syndrome. And people that I've seen with this toxidrome here in Atlanta, for example, or in Beirut, come in, agitated. They come in delirious. They hallucinate. Okay, that's why we say in the mnemonic, mad as a hatter. Please put in the chat why it's called mad as a hatter, and we can wait a little bit and then we can reveal the reason why it's called mad as a hatter. But mad as a hatter is an important finding in these patients. They're usually agitated. They're not very violent. They don't have to be violent. They're just a little bit disoriented, confused, and they can be hallucinating, which can stress them out and make them even more agitated about their own condition. We say they have Lilliputian hallucinations. Lilliputian, also, there's another quiz for you to kind of guess why it's called Lilliputian hallucinations. So that's an important finding. They also come in tachycardic. They come in tachycardic because, again, you're blocking the muscarinic receptor and you're getting tachycardia instead of bradycardia that you see with the cholinergic syndrome. They are tachycardic, they are hyperthermic. They are hyperthermic because they are agitated and their sweat glands are constricted. They're not producing sweat, so they're unable to dissipate heat. So they're usually hot and dry. They're hot and dry and altered. They're blind as a bat because they have cycloplegia. The pupil is paralyzed. Could be also dilated. So that makes them suffer from blurred vision or decreased vision. That's why they're called blind as a bat. They are dry as a bone because, like I said, they are, not sweating. And they are full as a flask because their bladder is distended and they're constipated. And one of the important things that I always check is if the bladder is distended because, they may not be able to tell you that they want to urinate and they need a Foley catheter. Often I've seen, well, now I shouldn't say often. Occasionally I've seen that just putting the Foley catheter in decreases their agitation. Sometimes they're just agitated because their bladder is distended and they are hurting. That's why they're super agitated. So yeah, so that's the anticholinergic uh, toxidrome, and in the U.S. we see a lot of people abusing diphenhydramine, or they abuse dextromethorphan in the cough and cold medicine. So that's a cause of anticholinergic toxicity that we see in the ED in the U.S. There are some antipsychotics, phenothiazines, that have anticholinergic effects. Tricyclic antidepressants like amitriptyline, nortriptyline will have anticholinergic toxicity. Remember that. Um, People that abuse these cough and cold medicine, like Robitussin, we call them robotripping because they abuse it. Often they enter the pharmacy, they drink the bottle in the pharmacy, so they evade detection, and then they leave the pharmacy without anything on them, so they are not detected, and they drink the bottle in the pharmacy lanes where they are where nobody's watching. We call them robotripping. Once in a while, we see a plant poisoning. Not very common for us in Atlanta. More common for me in Lebanon. My experience, at least, has been more common with these cases in Lebanon, where I've seen the plant poisonings. There are plants that contain chemicals, alkaloids, that block the muscarinic acetylcholine receptor. This is an outbreak we had in Lebanon. In Lebanon, there's a dish called karbuza, which is made with the leaves of this plant to the right of the screen. It is often collected by the Arabic Bedouins, nomads that live in Lebanon. We have this population of nomads, Bedouins that live in tents in Lebanon. There are not many of them, but they traditionally pick this leaf in the spring and they saute it and put some lemon juice and garlic, and it's called karbuza and it's consumed in that period. Uh, this plant ended up in a table of a family, that family of four that developed anticholinergic toxicity and came to AUB. Parents and kids became admitted because of the agitation. And one second, sorry. Sorry about that. And they got admitted to the hospital, so they took over some resources from AUB, and it was actually mixed up with this plant here in the middle. We were able to retrieve the samples, and this is Dhatura stramonium, which you see here, or Jimson weed. So people picked the plant by mistake. And we had another case a month later, a man who ingested this, and we thought he was an acute stroke. He came in altered, and they thought it was an acute stroke. They called the neurology stroke team, and they rushed him for kind of a stroke workup. Ended up being this plant again, Datura stramonium. So yeah, so that's the one experience I have. There are other plants that contain these alkaloids that are anticholinergic or muscarinic receptor antagonists, like angel's trumpet, and I don't know what you have in Nepal, deadly nightshade with Atropa belladonna. Belladonna is also another term that you may wonder why it's called belladonna. We'll talk about these. We have three questions, right, Ramu, that we were supposed to discuss.
Right.
And then black henbane with hyoscyamus niger, which contain hyoscyamine. These alkaloids are all anticholinergic. What do you all have in Nepal, Ramu? I'm gonna open up the chat, see what's been written here already.
What Dhatura is very common, but the angel's trumpet. There is a plant. Rajesh, we talked about this. Is it called what does Nirmasi look like?
निर्मसी भनेको त डेल्फिना
Delphine.
Delphinium. Yeah, delphinium. Yeah, I heard. We had that case with you in Nepal. I remember that.
कार्डियक अरिथमियाज
Yeah,
due
yeah,
to
we had
delphin.
But there are like angel trumpets looking plants all across Nepal, but I don't know what their names are.
It's good to
Um,
it's good to do that, Ramu and Rajesh. It's good to maybe come up with a discussion with your botanist. So one of the best things that I've done in these cases is have a botanist. So I have a couple of botanists, one in Lebanon, one at Emory, that I communicate with on a regular basis. Like you could probably have one at Brown to support, and then somebody in Nepal, and you can communicate. And Dua from Oman and Emory, responded correctly that the Mad Hatter is because people used to make those hats with the felt. They used to get exposed to mercury and get mercury neurotoxicity, which is also seen in the Alice in the Wonderland movie. And that's why we say mad as a hatter. Although mad as a hatter refers to mercury toxicity, not anticholinergic, but we just use that term, mad as a hatter. And then the other question was, what is Lilliputian hallucinations with the anticholinergic syndrome? And that's from that movie. What is that movie? This guy that goes to a world where everyone is small. Gulliver's Travel or something, right? Gulliver's Travels. In Gulliver's Travels, people are small, right? So Lilliputian, you'll ask the patient, and they'll tell you they're seeing small people in the room, or they'll see. Well, sometimes they're not very lucid. They'll say they're seeing dots that are moving around the room. That's is called Lilliputian hallucinations. And the third question was belladonna. Why is it called belladonna or beautiful woman? It's because it used to be used in Italy in the Renaissance, and women would have dilated pupils, and that would be a sign of beauty. So that's why it's called atropa belladonna. Anyway, few fun facts. Excellent. So yeah, so more recently in Lebanon, we had about, I don't know, several cases. How many cases did we have in Lebanon? 7 or 8? Because we
Hello.
have a
I think
consulting
I
service
think
with
seven
7
cases.
cases. So we had 7 cases of lupin. In Arabic, this is called turmus. It's very common. You go to Lebanon or any Middle Eastern country, when you go to a restaurant, before you eat the food, they'll put this for free on the table. They're usually like beans that quite tasty. They're salty. You put them in your mouth. You remove the skin, and you have this bean in there, and you chew it. And you need to prepare it properly by soaking it in water and throw in the water soak, and then soak it again to remove the alkaloid from it. And we've had about 7 cases of anticholinergic toxicity from it. So this is lupin beans. And we thought that this was a problem because there are 2 types of lupin beans. There are the bitter ones and the sweet ones. The bitter ones have more alkaloids. And we felt that maybe in the season of restaurants in the summer, they were running out of time to make them properly, or they're also buying the bitter ones because of the market supply and demand. So how do you one of the WhatsApp messages I got today was somebody was asking, how do you manage this in the ED? What do you do? So usually, you have to get your history, and if you're lucky, you have a history. Sometimes it's easy. They tell you I overdose on dextromethorphan, or I overdose on Benadryl, or I took this plant. So those are easy cases. Sometimes you don't have a history, so then you need to recognize the toxidrome, and the toxidrome may be incomplete. So you have to, take things into consideration, assess, reassess, make a differential diagnosis, and work them up that way. The ones that are difficult, to assess, I remember a case at Grady when I was a fellow. This was a big man, large body, young man, presented with altometastasis and fever. This was a tough case for me because this big, large man with fever and altometastasis required a lumbar puncture. And I was not excited about, attempting this lumbar puncture on this big man with agitation and altometastasis and fever. So sometimes it's difficult. I mean, he was tachycardic, he was febrile, he was altered, he had dilated pupils, but what do I do? There was no history. So in the meantime, you do your basic labs. You look for your co-ingestions, as acetaminophen salicylates, and then you get an EKG. We always get an EKG. We'll talk more about that later, but we always get an EKG in overdoses or suspected overdoses. And we consider these other causes, maybe a CT of the head, if indicated, or maybe a lumbar puncture, if indicated. But essentially supportive care. Now, people that are agitated, you are going to give them benzodiazepines to sedate them. That's the best thing to do. Certainly, if someone is febrile, I would not give them haloperidol because I worry about neuroleptic malignant syndrome, NMS, which is potentially causing ultimate fever, of course, with rigidity. but I avoid phenothiazines for sedation of people in general. I don't like to give phenothiazines for sedation. My first line is always benzodiazepines. So you'll give them some benzodiazepines, and of course, if they're hyperthermic, dangerously hyperthermic, you have to cool them rapidly because hyperthermia can be lethal in itself by causing muscle damage, lactic acidosis, hyperkalemia, and the rest. So you have to be aggressive with people that are really hyperthermic. I'm talking about 44 degrees Celsius, where you have to do this within 30 minutes. And I'm not going to dwell on that too much, but remember that the severe hyperthermia is a life-threatening emergency that requires prompt actions and then interventions that will give you a result within 30 minutes. Of course, I forgot to mention that in the muscarinic effects in the central nervous system of these anticholinergic alkaloids, you can get seizures as well. So if they have seizures, you should give them, again, benzodiazepines. There's no room here to give phenytoin or levetiracetam. This is a role here for benzodiazepines or barbiturates or propofol. These are all potential anti-epileptics in toxic seizures. So that's kind of what you do. There's no magic about the management, except that there is an antidote called physostigmine. So let's talk about physostigmine a little bit. First of all, I told you it's not an exotic drug. This is a pesticide. It's a pesticide similar to organophosphates. It belongs to the class of carbamates. There are carbamate pesticides used all around the world, but this one is medicinal. It is the cousin of neostigmine, which is used in myasthenia gravis. It is the cousin of pyridostigmine that is used by soldiers concerned of getting exposed to nerve agents. It was used in the Gulf War by US soldiers. They would take pyridostigmine, I think 3 times a day, because it's short acting, and they will maintain this level of pyridostigmine in their body so that if they get exposed to a nerve agent, which will block their other unoccupied acetylcholinesterase enzymes, when this pyridostigmine effect goes away, they'll have a supply basically of acetylcholinesterase enzymes that were not affected by the nerve agent. That was the idea behind using pyridostigmine. And the reason why the soldiers were able to take this drug safely is because it did not go through the blood-brain barrier and did not have any central nervous system effects. Okay, so that was great. Same with neostigmine. Mestinon doesn't cross to the brain. So those drugs can be given to people in that way. And I'm sure you use neostigmine for your cobras, potentially. So physostigmine is unique because it crosses the blood-brain barrier and therefore can reverse the delirium. And that's what you want. The problem with physostigmine is that it's short-acting. A big problem because you give it, and then about 30 minutes to an hour later, the positive effects you've received from it go away. So that's the issue with physostigmine. It's also in the US expensive. So these are some of the issues with physostigmine in the reversibility and sometimes, not being available or being expensive. Currently in the US, we don't have the manufacturer anymore. We're relying on a German manufacturer that makes this drug in Germany, and we ship it to the US. Now, as I said, it's a pesticide. It's similar to an organophosphate. It's a carbamate. It's going to inhibit the acetylcholinesterase enzyme and cause an increase of acetylcholine in the muscarinic receptors as well as the nicotinic receptors. Okay, so you can see side effects from that, but it's not as potent as your carbamate pesticide or your regular organophosphate pesticides. But you can see vomiting from it. You can see seizures. You can see bradycardia. So, people don't necessarily like to do that, to see that in their patient. right? Especially when you tell them that the effect is only going to last for an hour. So they're going to say, okay, well, why do I really need this drug? I could just, sedate them with benzodiazepines and wait for this overdose to clear off. I don't want to give them something. I already gave them a bunch of benzodiazepines, so they're a little sleepy right now. And now I'm going to make them vomit, or I'm going to make them seize. So some people get concerned about that. The other issue is that one of our mentors in toxicology, Dr. Paul Pentel, in 1980, reported 2 cases in which you had bad complications after giving physostigmine. Now, at the time, in the 80s, there were many more tricyclic antidepressant overdoses. And like I mentioned to you earlier, tricyclic antidepressants in an overdose can cause anticholinergic syndrome and can also cause sodium channel blockade with a wide QRS on the EKG and are predisposed to seizures and cardiac dysrhythmias. These 2 cases were pretty severe tricyclic antidepressant cases. And they also had wide QRS. So they were already sick. Now, at the time, they used to give physostigmine more liberally. They used to give it to TCA overdoses. It used to be part of the antidote cocktail. When you had somebody with an overdose, they're altered, you'd give them, naloxone, you'd give them physostigmine, you'd give them glucose, right? You used to do that as a cocktail in the 70s. So they gave those patients physostigmine, and they both had asystolic cardiac arrest. One of them survived, the other one survived, but then had brain death. And then another one of our mentors and leaders, Dr. Michael Shannon, in 98, also reported a similar case. But the question is, are these cases, have this bad outcome because of the physostigmine, or is it because they're already sick with a cardiotoxic overdose? But nevertheless, those cases really, Dr. Pentel's cases, caused many clinicians to say, why do I want to use physostigmine? It's short-acting. It's expensive or not available. It causes vomiting, bradycardia, and seizures, potentially. And there are these cases of asystole when given to somebody with a TCA. So when I was a fellow, I graduated in 2005. So 20 years ago, when I graduated, if you asked me about physostigmine, I would say to you, what for? If I'm going to give it, I kind of want to know exactly what they took. I don't want to give it to an unknown, because what if this unknown is a TCA overdose? And if you want to give it, I want to check an EKG first. I want to look at the EKG myself and make sure there's no wide QRS or a tall R wave in AVR greater than 3 millimeters. These are, to me, contraindications to giving physostigmine, because they could have a TCA overdose. And because of these case reports, I don't want to give it. If you tell me this patient took angel's trumpet, or somebody saw them eat the angel's trumpet, so there's no TCA, and the EKG is normal, then I would consider it. But then I would say, well, short acting, what's the point? So that was my practice, okay? Until I saw that patient in my fellowship, at the end of my fellowship that I mentioned to you, the big guy with fever and altered mental status. My attending at the time, Dr. Jerry Thomas, proposed that we give physostigmine as a diagnostic tool to avoid the lumbar puncture. So I did. And that patient woke up, cleared up, and told me he overdosed on a muscle relaxant, like cyclobenzaprine, which also causes anticholinergic toxicity. So I avoided the lumbar puncture. Now, about an hour later, he became delirious again, but I knew I had already now confirmed my history and avoided the lumbar puncture. That was the first time that I've ever used physostigmine in my career. Fast forward, recently, I've become more comfortable with using physostigmine because of some of the literature that was published by colleagues of ours, which is summarized in this study, which was a randomized double-blind control study where they gave physostigmine versus lorazepam. Now, they excluded patients with TCA. They excluded patients with asthma because remember, a carbamate can cause bronchospasm. They excluded some patients that, they were very sick. So, but still, they did the study on 19 patients and they compared the physostigmine, which is a dose here, max of 2 milligrams. You can always give 1 milligram. That's what I always give, start slow and then to avoid the bradycardia and the vomiting. But they used up to 2 milligrams twice because remember, it's short acting. And then they put them on an infusion for 4 hours. Same thing with the benzodiazepine. They used lorazepam, 2 milligrams twice, and then an infusion. So reasonable study in that way. And similar patients, a little bit in terms of the breakdown. Table 1 doesn't have any significant findings. And you notice here that at the end of the 4-hour infusion, the lorazepam group was still delirious, whereas 80% of the physostigmine group had stopped being delirious. And you see the effects within one bolus, second bolus, and infusion, the decrease in the delirium percent. So effective drug right here, clearly an effective drug, as measured by the RAS scores. And you see the delirium here resolving with physostigmine and persisting with benzodiazepine. And you notice here, of course, that the lorazepam dosing was much higher in the lorazepam group, which is a problem too because it causes sedation, ICU admission, step-down admission for sedation. So in summary, using physostigmine should be in the right patient. About 2 months ago, and Dua was there, we had an older man, age 80, who overdosed on Benadryl. He was agitated. Very agitated. He was in the bed. The beds have metal rails. He was hitting his head to the bed. He was hitting his arms to the bed. He was physically restrained, getting benzodiazepine, miserable. And we knew he was a Benadryl overdose. I was concerned a little bit about Benadryl because Benadryl, remember, can cause sodium channel blockade too, and can cause wide QRS and R wave and AVR. So remember that. So I got the EKG. EKG was normal, did not have any of those sodium channel blockade signs. I knew he took Benadryl, and I decided to give him physostigmine. I started slow. I gave him 1 milligram. Then I think I gave him the second milligram, and he woke up. He got a little bit nauseated. He did not vomit. His heart rate went from 120 to about 80. I got nervous a little bit. Is he going to get bradycardia on me? But he didn't. And, he confirmed the history. And something interesting happened. Although the effect went away after about an hour, hour and a half, although he got delirious again, it wasn't as bad. So I feel like I broke the cycle. And people report that with physostigmine. They say, we were able to break the cycle. Whether it's true or whether it's because, temporally, the patient was getting better anyway. It's hard to tell, but that's anecdotal, that you feel like you broke the cycle. The third time I used physostigmine was me and my colleague, Dr. Giringer. We worked together on that case because we were, different time of the assessment. She's a toxicologist as well. And it was a young girl who was like in her 20s, young 20s, and she was also miserable with her agitation. And she got better with the physostigmine. Now, that one required several doses. We repeated the doses up to 3 times, I think. So it wasn't as easy as this older man, but I think it was useful in that case too. So for me now, the right patient, and what is the right patient? That's going to be a subjective assessment by the clinician. But to me, the right patient is somebody, of course, who's agitated, right? That's causing problems to their body, to the environment, to their catheters, their lines. They're going to hurt themselves. Somebody who is diagnostic challenge. Is this a encephalitis that needs a lumbar puncture or an MRI, or can it just be an overdose? Those are the right patients. Certainly, those are asthmatic, wheezing, with the history of seizures, those with the signs of sodium channel blockade on the EKG may not be your best patients to do that. Now, even the sodium channel blockade by EKG, that one also has been questioned. There are some studies out there looking at, can we give it to people with the sodium channel blockade? But that is, I think, still in my mind at least, not settled. Because it's hard to tell with these cases that I just reported to you. The temporal relationship between the physostigmine administration and the cardiac arrest was significant. And there are some hypothetical ways that physostigmine can potentiate, the seizures, for example. But it doesn't really cause sodium channel blockade, so the error is less clearly related to the physostigmine administration, but temporally it was. So I hope, you get to use this antidote in the future. I'm not sure if it's available. Using neostigmine, for example, in these cases would not help your delirium. So there's less use for it in that case, in your case. Or pyridostigmine, which is oral, probably not useful either. It doesn't cross the blood-brain barrier. So you may want to ask yourself, is this antidote available in Nepal or wherever you are from, attending this webinar today? Finding out if it's available or not, it does have potential uses. So I think this is probably my last slide. I have here the Minatox QR code if people are interested and the reference. Any questions? Back to you, Dr. Ramu and Dr. Rajesh.
Thank you, Dr. Kazzi. Very, very nice kind of overview and management for anticholinergic exposure. We see this a lot during certain festivals in Nepal, like especially during Shivaratri. We get a lot of these cases, even places in far west Nepal where we work in Bailpata Hospital, and we have Rishika here joining from Bailpata,
Why is that?
who sees this case. Well, it's a festival where Shiva is the Lord, sort of who does get high per the tradition. So during that time, people do participate in Dhatura, like people take Dhatura bhang, things like that.
Oh,
So,
wow.
a lot of cases of kind of anticholinergic toxicities. I don't think physostigmine is that widely available in Nepal. And if any of you have physostigmine, you can please unmute yourself and talk about that. But do you have any questions? Does anyone have questions on the anticholinergic part? And I know there are a lot of questions on the organophosphate side that I'll ask you, Dr. Kazi. But anyone have any questions on
I'm
this
curious
part?
about the physostigmine. Can somebody comment on the physostigmine availability?
I know that at Bailpata we don't have physostigmine, which is a rural hospital in far west Nepal.
Somebody needs to write this up. I mean, your poison center should go to that festival and set up, seriously, I mean, set up.
That festival is all across Nepal, so that the festival comes to the poison center.
Well, have you collected data? You should collect data next time you have the festival.
Yeah.
And also, another idea for people to consider doing an antidote study in Nepal. I've done a lot of these studies, and they're easy to do and they're rewarding. Survey-based studies, cross-sectional studies, to kind of get an idea what antidotes. Actually, in the US, poison centers are required to maintain an antidote database. So, Ramu, let's see if you have somebody, one of your physicians, specialists, are interested in something like that.
Yeah. Yeah, and maybe one of the participants here, if they're interested, they can always email us.
There were some questions. Looks like there are no questions about. Okay, let's see. Any management idea when histamine is not available? Yeah, so if physostigmine is not available, you have to rely on benzodiazepines to calm them down, and then wait, and then supportive care. Good question.
Yeah, benzodiazepines are your biggest friend here. Any other question? Rajesh, you're going to say something.
Yeah, I just wanted to comment on availability of physostigmine. It's available in India and in the Tarai region, which borders India. It's easily available, and also in few of the tertiary centers, it's available, not widely available. Yeah, that's all I wanted to say. And
So it's not always available. So it may be available in some areas.
Yeah, it's available in some areas only, not everywhere. So it's very.
And Dr. Sarban is saying again, Dr. Sarban, you do supportive care. You stuck with supportive care in these cases. Benzodiazepines, calm them down, protect them from harming themselves or self-injury, and wait for them to get better. and make sure they're not hyperthermic, decompress their bladder if it's full, and like I said, protect them from metabolic complications. Okay.
There's a question about, so Rishika is asking, is the indication to start physostigmine mostly symptoms of agitation?
Yes. This is the one, the most meaningful one. There's a question about what part of the Dhatura, what part of the Jimson weed.
I think it's the seeds, right? It has to be.
I think I'm not up to, I'm up my disclosure. I'm not a big fan of plants, so I'm not somebody looking around learning about them that much. I just try to get by with whatever I need to know, just to manage the cases. But I'll have to look this up. Let's look it up together because I think it's everything. Let's see. Toxicity, all parts of the plant, yep, contain the alkaloids. So all parts. But I think people, Ramu, they do the seeds because maybe it's easier. What benzodiazepine can we use? It doesn't matter what benzodiazepine. And this study that I just showed you was 2 milligrams times 2 with an infusion. It doesn't matter. You can, but with benzodiazepine, you give as much as needed.
Right. I'm a fan of the way I do it is if there is I have midazolam available. We call it by Versed is the common name, and we just give it PRN like every 15 minutes or so based on whatever symptoms you want. But it's a short acting, short off. I really like midazolam if you have it. So that's my preference.
Yeah. Also depends what you have in your hospital.
All right. So why don't we, Dr. Kazzi? So some of the questions around cholinergic, so now which is the opposite spectrum of this, and one of the most common poisoning in Nepal is organophosphates. And I think a lot of questions that we got around this was, with atropine. One is sort of, what is the maintenance of atropine once you have, atropinized them and maybe gotten the symptoms kind of under control, and what is the goal of treating with atropine? Like, what sort of symptoms are you looking for? So if you can kind of maybe give a summary of those, that would be really helpful.
So it's funny that this came up today. We have 2 cases right now in Atlanta of organophosphate poisoning that I managed last week. One of them currently, believe it or not, Ramu, is on ECMO. So I've never seen anybody. We're going to present those in future meetings. The first one was a dichlorovos overdose, which is a dimethoxy organophosphate. The second one was acephate, which is also a dimethoxy organophosphate. Both of them were oxones. Both of them had some muscarinic effects with initially vomiting, diarrhea, followed by ultra status, and then bronchorrhea. And both of them required atropinization. But fortunately, none of them required high doses like some of our colleagues in India that report very high doses. Somebody, one of your audience members said 100 milligram per hour or something, So my cases, we only required 0.4 milligram per hour. What I did is I atropinized initially by giving 4 milligrams IV, and I was about to double it every 10 minutes, but I didn't have to, So 4 milligram was enough. Then I put them on 10% of that dose, which is 0.4 per hour. If I had given more, I would have probably had to give more per hour. Usually 10 to 20% of the initial dose required to control the bronchorrhea and bronchospasm is what I usually do per hour. And then you continue this atropine, and of course, then they potentially get atropine delirium and hyperthermia and agitation. You have to balance those 2 things together. We also gave pralidoxime in Atlanta. In Atlanta, we give pralidoxime 2 grams IV, followed by 8 milligram per kilogram per hour, which is about 500 milligram per hour infusion. And we did it because these are methoxy organophosphates that age rapidly, They don't respond. They do respond to pyridoxine, but they age rapidly. So we started those rapidly initially, uh, and our patients, had fasciculations as well and got intubated. So yeah, and then we continue the pyridoxine and we try to monitor the neuromuscular function with spontaneous breathing treatment trials, spontaneous breathing trials. We look at their muscle function of their neck, try to see if we can wean the atropine and the pyridoxine. The atropine also is weaned, based on the bronchoria, bronchospasm, basically. But the neuromuscular function is what guides your pyridoxine management. So the patient on ECMO developed potentially either aspiration pneumonia. Remember, these pesticides can also contain hydrocarbons, and this was an illegally imported pesticide into the U.S. This diclorovoz is not available, but they brought it from Nigeria, we believe, and and then ended up having ARDS and was transferred to ECMO, VV ECMO at Keystone. So that's where we are with that case. The SF8 case did better. I need to follow up on those cases to see if they're completely what they're doing today. But did that cover all the questions that we had on the WhatsApp? Anoop, maybe Anoop has the questions.
Yeah, I think that covers most of them. Let me just see here. Does anyone else have questions around atropine here, cholinergic organophosphates?
We are developing a pesticide course, a free online pesticide course, Minatox, in partnership with the Rabat Collaboration Center and the Morocco Poison Center. This course with modules online and a certificate and an exam can be made available to your colleagues, Ramu, when we're done with that.
Okay, that sounds great. There is a question here from, okay, there's a few questions.
In what cases of organophosphate signs we stop pyridoxine? With organophosphates, when do you stop pyridoxine? That's a great question. No, I wanna learn from you about organophosphates. My experience is more than many in the U.S., but very little compared to our colleagues in Nepal or in India. So, but I'll tell you what but I have a lot of friends that's why I'm very fortunate to have friends like Dr. Ashish Balla in Chandigarh, who, when he was my guest in Atlanta, his talk title was pyridoxine for organophosphate poisoning. I have not given any in 10 years. So Dr. Balla, for example, doesn't use any pyridoxine. And his data is mortality data is similar to those that use pyridoxine. So there's also a study by Dr. Michael Elliston, who's one of our leading, he's probably the leading researcher or one of the 2 or 3 leaders in organophosphate poisoning research in the world, with his work in Sri Lanka, showed in a double-blind randomized control trial that pyridoxine didn't make a difference. So that's it's really supportive care with atropine and ventilation, oxygenation. In the US, though, we still use it. Certainly, also, you want to use it in nerve agent poisoning. So, that's, to me, though, I use it if you have neuromuscular findings. Definitely want to use it. But in these cases that I just told you about, those 2 cases, when I saw they were dimethoxys and I saw they were sick, I decided not to wait because I had the antidote available and I decided to start because of the aging issue. One of the cases was fasciculating already, so that was an easier decision. The first one was not fasciculating, was just vomiting, had diarrhea. But I pulled the trigger because I have the antidote. In the US, we use it, and they're sick. So I don't know that I may have not answered your question properly. I recommend that Anoop invites Dr. Balla, invites Dr. Edelston to do a talk on this. They're the real experts. I know that there's some studies in India where they gave high dose pyridoxine, 1 gram per hour instead of 500 milligram per hour. And they published that in the Lancet and they had a difference in outcomes. But Edelston's study did not show a difference in outcomes. So yeah. And, there are other things also involved in this. For example, some hospitals like Dr. Balla's hospital in Chandigarh, PGR Chandigarh, they don't get the patients quickly. They're transferred to them. So like when you have a delay in transfer and arrival, by that time you have less efficacy of pyridoxine. It also depends on what specific organophosphate. It was dimethoxy or diethoxy. And diethoxys respond to pyridoxine and they have a longer aging half-life, but the dimethoxy, they're more likely to age rapidly, but they do respond. So there's some like pros and cons depending on which organophosphate you're talking about and the time to presentation.
There is a question regarding just like atropine, and Gosai said, if a patient is on maintenance for atropine, develops restlessness, how long do we stop the infusion for, and when do we restart the infusion, and the rate of the infusion?
Yeah, that's very challenging because if you think that they are atropine delirious, do you try to use glycopyrrolate, which has less CNS effects, switch them to glycopyrrolate, or do you just stop it or decrease it, wean it instead of stopping it? Depending if they're intubated, that's fine, but if they're not, you may get them worse if you stop it suddenly. So it's really a clinical adjustment at the bedside, trial and error to see what works best for the patient. There's another interesting question on top. When do we stop the pyridoxine? So typically, you want to stop the pyridoxine when you notice that the neuromuscular function is back. You want them to be able to squeeze on your hand, to raise their neck off the bed, a good spontaneous breathing trial. The other thing that some people do in India, I haven't experienced that yet, but you can do an EMG nerve conduction study, and there are specific patterns on the EMG that tell you that you should not stop or that you should stop. Because the issue is if you stop and then you continue watching the patient for 24 to 48 hours, they can develop something called the intermediate syndrome, where they develop cranial nerve palsy, some weakness again, that does not respond to pyridoxine. So you get this intermediate syndrome risk later on.
Yeah. Any other questions? These are great. And I think for the rest, with the atropine and restlessness, like if you still have bronchuria and you need atropine, I'm
Yeah.
wondering for the restlessness, if you can give a little bit of, some other, like maybe very low dose benzo. I don't know if that would,
Yeah. Yeah,
uh,
sure.
sort of
Sure.
work. I think, atropine probably should
They're
be
probably
given.
going to be on some benzos because if they're intubated, right? I mean, you
Right.
would think they'll probably be on benzos.
Right.
And oh, one more thing. Remember that they can cause seizures, right? These organophosphates. So you want to so I did an EEG on those patients. And of course, benzos are preferred as a sedation drug because of the potential seizures. Remember that too. They could be seizing if they're intubated. You can't tell.
All right. I think we are coming to an end. We have a few minutes if anyone has more questions, but if not, I think that's okay. Um, okay, I'm asked, please share.
Pregnancy and prognosis. Oh man. I mean, I'm gonna answer you the classic answer for anything OB. The health of the mother is the best treatment for the health of the baby, right? So that's one thing I want to say. The second thing I want to say is that I had one experience that we published as an abstract, actually, not as a paper. We had a pregnant near-term woman who overdosed on organophosphate, and then we because of the risk, there's some case reports and some evidence on the baby, like effect of the pesticide on the baby. So we rushed the patient to a C-section and delivered the baby. So that's one case we reported. I don't remember the details. I think we measured acetylcholinesterase levels in the mother and the baby, and it's controversial, but it's not clear the evidence what's going to be transferred to the baby. But I remember that in that one case we delivered the baby just because she was pregnant and near term. So
Yeah, that's
work
quite
with
it.
your OB doctor on that one and
Yeah.
look up the literature on if you have a case like that. I don't remember the details of the literature on that one. I remember it wasn't straightforward.
All right. Okay, well, thank you. There's one more.
Oh, this is interesting. That's a great question from Dr. Gotsai, because this happens a lot. And I'm learning about this, Dr. Kotsai, because I'm seeing these pyrethrin poisonings, like cypermethrin or something like that. And then they have with them organophosphate, some of them. So it's like hard to tell. So yeah, giving an atropine challenge, see if they get better. Yeah, sure. That's like a good idea. If you feel like you don't know if this is organophosphate, you give some atropine, they get better from the secretions, or maybe worthwhile trying. All clinical, but there are these compounds that contain a pyrethrin, I mean a pyrethroid, a synthetic pyrethroid, and an organophosphate, which can make things complicated. And also pyrethroids, they are going to sometimes look like um, because they take like type 1 pyrethroids can cause tremors, and then type 2 can cause salivation. So yeah, so they can confuse you a little bit.
All right, we are coming to an end. So unfortunately, no more questions. This was a great discussion today. Thank you so much to all our participants, first of all, for joining and giving time and being engaged with the Poison Center. Hopefully, you know the phone number for the Poison Center. It's 450-2011. And you can call 24/7, and we have experts available to help you guide in this type of cases as well. And I would like to thank all our Poison Center staff here, spies and all the partners that have joined today from Nepal. And finally, I would like to thank our speaker, Dr. Ziad Kazzi. I think this was really needed talk on anticholinergic plants, kind of focused on Dhatura, as well as a lot of questions about cholinergic syndrome. These are really interesting and important topic for us. We will have this webinar on our YouTube page available, including all our other webinars, which are on our YouTube page. So if you have missed any of our webinars, you can go and watch it there. And you can always contact us to reach out to the speakers. We have direct access to them. So again, please join me in thanking Dr. Ziad Kazzi for today's wonderful presentation, and hope to see you all next month, where we'll bring a different speaker, probably from Australia next time.
Thank you.
Thank you all. Namaste.
Namaste.